Well, good evening from America, everybody, and whatever time of the world it is where you are. Welcome to tonight's AO webinar, the 3Cases Fireside Chat Series. Tonight's webinar is going to focus on scaphoid nonunion. The chair of the Hand Education Committee, Marco Rizzo, and the Hand Education Committee put together this series for you. So tonight I'll be moderating. I'm Jeff Lawton from University of Michigan. Our sage is Jim Higgins from Curtis Hand Center, my alma mater in Baltimore. Also joining us, Rob Wysocki from Rush and Rachel Pigott from Johns Hopkins in Baltimore. None of us have any financial relationships that relate to this talk, and all were mitigated. So for those of you interested in CME, this is a series, and you're certainly welcome to claim those talks you participated in. At the end of the series, you'll be able to receive the CME. In terms of those of you familiar, AO is an independent nonprofit specialty society dedicated to education and improving the care of patients. It doesn't endorse a specific product or implant or screw or plate, etc. So you may see us demonstrate various things, and again, remember, it's for the educational purposes of a technique, not a specific how-to with a company's product. Just a word on Zoom etiquette, and many of you are very familiar with these. Your microphones have been muted. However, we do welcome your participation, and please send us questions, or certainly if there's any technical issues, through the question and answer box. Depending on the question and depending on our time, we'll either answer it directly or we may pose it to our professors. So thank you for that. Objectives for the learner. Again, we want to identify the radiographic and clinical criteria required in treatments, define appropriate surgical anatomy, recognize potential pitfalls, and hopefully develop some strategies to avoid these, and have a review of the literature with regards to outcomes. So this is part of a series. As you can see, we have upcoming talks monthly: upper extremity flaps, biceps injuries, sports injuries of the hand, metacarpal fractures, brachial plexus, distal radial malunion, and DRUJ arthritis. So a number of great talks coming up. As a background, we also have ongoing webinars. So Jay Bridgman's going to do a soft tissue and flap coverage talk. Dr. Bott's going to do a great talk that I've seen before on the mangled hand, and I have a terrible triad injuries of the elbow this coming fall. We have in-person courses as well in terms of regional hand and wrist fracture courses in Ann Arbor and Dallas coming up, as well as in-person courses in Las Vegas and Florida that AO is putting on. So for those of you who are interested, this will be up on our YouTube page after 24 hours and available for reviewing. So we have a great lineup, as I said. So I'm going to start off with scaphoid proximal pull. That'll be followed by Jim Higgins talking about free vascularized graft. And again, we welcome interaction. So if there's any questions, we can certainly pose them to the professors. Rachel's going to talk about hand therapy for scaphoid nonunions. And finally, Rob Wysocki is going to talk about complications. So again, we'll talk about proximal pull nonunions. And our objectives are to develop a method to critically evaluate failures of scaphoid healing, be they yours or be they from elsewhere. Try to employ an algorithm to determine treatment, looking at things like vascularized graft versus non-vascularized graft, volar approach versus dorsal approach, and then wading through various fixation options and trying to gain knowledge of specific surgical treatments. So as all of you know, the scaphoid is the most commonly fractured bone, has a non-union rate of about 5 to 15%, and it's been likened to a peanut-shaped bone or a cashew-shaped bone. But proximal pull, which I'm going to talk about, unfortunately has an even higher rate of non-union and a rate of avascular necrosis, as you know. So these are some of the more challenging fractures. So when we talk about treatment of proximal pull nonunions, we typically are talking about a dorsal approach. In terms of our fixation, it can either be with K-wires or a compression screw. And again, we can look at the role for non-vascularized graft versus vascularized graft. So as we wade through these various issues, Union rates have been shown to be as good as 94% with a compression screw, but unfortunately, smaller fractures or those that are only able to stabilize with K-wires don't have the same success rate, with union rates of 77% quoted with K-wires. But we're talking about what may be a small proximal pull, and you have to think about screws. So this is just a typical commercially available screw. And remember that the trailing diameter of this thread can be up to 3.6 millimeters. So again, when we're talking about these small proximal pulls, this can be a challenge with some of the more traditional screws. So one of the things that has really excited those that take care of scaphoids was this paper about 30 years ago. Carlos Seidenberg described this vascularized bone graft for scaphoid nonunion, and initially reported excellent results, 11 out of 11 healed. And here you see some of the original artwork, and you see the extended approach. You see the vascularized graft. You see dropping the tourniquet and seeing it bleed. And I'll show some more slides of this in a few minutes. But while Dr. Seidenberg's initial results were excellent, as with lots of other things, everyone tried it for different things. And the results were all over the map, as you see, from as low as 27% to as high as 100%. And the thought was this is because there were differences in fracture location, fixation types, and it was really not an apples to apples comparison. So it was sort of the, if you're a hammer, everything's a nail, and everything got a 1-2 ICSRA graft, and it turned out not to be ideal. So perhaps the final blow was this paper, and I'm sure Jim is going to have a number of Heinsberger studies in his talk, but this paper that came out that looked at the role for a pedicled local graft versus a free graft. And in this paper, the pedicled local grafts didn't fare that well. 4 out of 10 healed in 19 weeks versus 12 out of 12 free medial femoral condylar grafts in 12 weeks. So many thought that was sort of the final nail in the coffin for the 1-2 ICSRA graft. However, I would contend that it still does have a role, and this is sort of a great case for it in my mind. So this is a 17-year-old high school football player. Trainer taped his wrist for a quote-unquote sprain, made it through summer conditioning in the season, and presented just before the last game of the season with these x-rays. So again, we have all kinds of choices between non-vascularized graft and vascularized graft, all types of different sources for that vascularized graft. So again, I typically think of these as a dorsal approach. I try to use a small headless compression screw, and I sort of talk with the patient or the parents in this case, and sort of take the single best shot approach. And here you see this very small proximal pull, and it certainly looks sclerotic, so probably AVN. I want one operation that I think has the highest chance of success. So I did a 1-2 ICSRA graft. So here you see it's a right wrist, thumb is up and to the right, elbow is to the left. And here you see the freer is pointing to the pedicle here. This is the second dorsal compartment. There's the first dorsal compartment. Here you see the superficial radial nerve up in the sub-Q. And just to show you, it is truly a vascularized pedicle. In other words, you can see two vena comitatantes, and you can see the muscular wall of the artery where the little irrigating artery is obscured, and you don't see it as well as the veins. So this is his post-op and CT to show that it's healed. And it's his right wrist, so he got back good motion and was able to get back and play quarterback in college. So we wrote up our experience of these, and we tried to have one very specific indication, and that was small proximal pull fractures. We looked at 12 patients. As you can see, they tended to be young patients, mean age of 20. 8 of 12 had AVN, small fragments, and got 12 out of 12 to heal at 11 and a half weeks. So I don't think that this technique is for all fractures, but I think I would keep it in mind for very small proximal pull fractures. So the pendulum has really shifted. At the time of Zeidenberg, there was really wide adaptation and people started doing it for lots of different things. Then that got it a little bit of a bad name and it fell out of favor. There were other regional pedicled grafts. Certainly, Dean Satirianos has popularized a dorsal capsular graft, which I've used also with success. Jim Higgins is going to talk about the free medial femoral condylar graft. And again, that's been popularized and had great success. And then there's some people that say there's no need for vascularized graft, just cancellous bone and a compression screw. So I'll be interested to get our panelists' impressions at where does things sit now. So thanks. And with that, I will turn it over to our sage, Dr. Higgins.
Well, thanks very much. And I appreciate, Jeff, you sort of setting the table there. And I know that I'm perched in a position here where it's anticipated I'm going to start talking about the MFC flap or graft almost entirely. But I think what's maybe most valuable is I sometimes say to myself, you can't approach every nail with the same hammer. And your results were beautiful. And I believe the 1-2 ICS has its role, as well as a number of other vascularized and non-vascularized bone grafting procedures. So one of the most common questions from my fellows is, what is your algorithm? And for a long time, I couldn't answer that. And so I felt like it needed an answer and I should be organized in my own thinking. And so I think it might be a little bit helpful if I just outlined how I think about it, which parentheses does not mean it's correct. It just means the way I have sort of thought through this problem in my own mind. And the first thing is sort of how did we get to where we are? And if you just sort of historically with broad strokes look over the literature about the treatment of scaphoid nonunions, we noticed that early successes with cancellous grafting, the numbers were pretty low. And I'm going to populate these slides with a number of different articles if you ever wanted to see them or look them up. But this was sort of the trend at this time period. You can see the dates on these articles. It's in this sort of 70s, 80s. And it was felt that this was primarily because of the retrograde blood supply. And we all understand this concept of retrograde blood supply. And we teach this to our fellows and to our residents and registrars. And this is thought to be the reason this is a problematic bone. And it likely is, although it becomes a very difficult, multifaceted issue. We know that a waist fracture and a waist nonunion are both better than proximal pole fracture or proximal pole nonunions. The sort of landmark paper that changed our thinking in terms of vascularity was this incredibly frequently referenced article by David Green. We're all very familiar with this. We all know this article. This is incredibly simple and powerful study where Dr. Green looked and rated the bleeding of the proximal poles intraoperatively with or without tourniquet in this study, and then stratified those patients according to, poor, good, or no bleeding in the proximal half of the scaphoid. And this strongly correlated with success or failure in treating scaphoid nonunions. So we concluded that avascular necrosis of the proximal pole was a problem. Now we know from long bone studies that vascularized bone grafting works. So no matter what you hear at the podium, there's plenty of basis for the idea of vascularized bone grafting providing you the ability to primarily heal fractures rather than relying on creeping substitution. We know that's true, but for some reason within the world of the carpus, I think our society as a whole has come to doubt whether or not this is really necessary or truly a powerful tool. And that's because a lot of those studies on vascularized bone grafting are on long bones. If I were to offer you one study that you could reference to really say reliably, this proves to me that vascularized bone grafting is helpful even in the carpus within an intra-articular environment, not in a long bone. This is the study, and I won't go into all the details on it because of time, but certainly it's something that someone once showed me, and I've spoken to Alan Bishop, whose lab this came out of. This is an incredibly powerful dog model and well-controlled study, which clearly demonstrates that the vascularization of a bone flap does provide you with additional power in treating difficult nonunions. So if you believe that vascularized bone grafting helps, and you believe that avascular necrosis is a problem, that's where we were for a long time. And AVN became the well-established primary indication for vascularized bone grafting. And many of these articles would just almost as a dictum say that if you have AVN of the proximal pole, and you can figure out how you're going to determine that, that's when you should use vascularized bone grafting. That's when the timing, that period of our society is very clear when to use vascularized bone grafting and when not to. However, more recently, as you'll see all over the podium and all over the literature, it's now become really difficult to actually assess AVN. So use of the term AVN is difficult to say with any definitive means. Even the actual punctate bleeding of the proximal pole turns out to be not a very good gold standard. Or even biopsying. You could take biopsying samples of the bone at the non-union site, and sampling error could give you false positive, false negative. So it doesn't really correlate well with MRI with GAD, X-ray, CT scan, anything. So AVN has become a very difficult term to use and a very difficult indication for you to rely on in the office. So there's been a pendulum swing, I think, now, since we can't really reliably determine what AVN is. I think a lot of people are saying, well, hold on a minute, I'm not even sure when I should use vascularized bone grafting. And there's been a pendulum swing back towards non-vascularized bone grafting. And there is a role for it. And I think we all have to decide ourselves when we think it's indicated and when it's not. So I would say to you, there are actually 2 randomized controlled trials, because whenever you get in any of these talks, the answer is, well, boy, it wouldn't be great if we had a randomized controlled trial. And as it turns out, there are 2. And I was surprised when I culled through the literature. There are actually these 2, and they're both 1-2 ICSRA versus non-vascularized bone grafting. And one showed a no significant difference between the union rates, and the other one actually showed a slight advantage in the vascularized bone grafting over non-vascularized bone grafting. However, I would argue that both of these were not powerful enough to sort through some of the risk factors, because this assumes that all scaphoid non-unions are created equally. And I guess that's where I'm going with this. If you're in the office, and this is how I like to think about it and how I like to walk through this with my fellows, is you don't just walk in and say, I have a scaphoid non-union, and now I'm going to decide whether vascularized bone grafting or not is indicated. You have to think about all the factors that are at play. There are things in the literature that are preoperative factors. I mean, that's meaning the things that the patient came to you and presented you with these challenges. There are other things that are studied in the literature that are treatment factors. Did you use long arm cast or short arm cast? Did you use screws or pins? How good was your screw placement? Those are all related to your technique. But if we just focus on the preoperative factors, that's what's going to really guide you in making decisions in the office. And if you look through all of these things which have been studied in the literature, some of them will fall off because they don't actually show adequate power or adequate differences. And that includes patient age is irrelevant and gender is irrelevant. Avascular necrosis, I would argue, impossible for you to really discern, no matter how white your x-ray is. So really, it falls into these remaining categories of preoperative factors that I think at least are relevant for you to decide whether or not you're going to use vascularized bone grafting or not, and the technique. So and I'm going to try and stay on time here. Sorry, I'm rushing, but if you look at these 6 factors, the duration of non-union, and here the cutoff in general in the literature is the established non-union greater or less than 12 months old? Often this is an unknown, but if you know it's greater than 12 months old, that's an independent risk factor of failure. These are risk factors of failure of your non-union surgery, not failure of your scaphoid ORF, failure of your non-union surgery. Location of fracture, we know the proximal pole is more risky than the waist. By the way, a lot of people define that in a lot of different ways, but we know the more proximal you are, the riskier you are. Size and fragmentation of proximal pole, this is super worrisome if it's fragmented. In fact, this to me would lead to an osteochondral reconstruction. We can talk more about that. Previous instrumentation, this is an incredibly worrisome risk factor. If you were to weight these risk factors, I would say previous instrumentation probably the most worrisome. Humpback deformity, and there's a lot of ways characteristics or displacement is described, but I would just simplify it as yes or no with a humpback. And then lastly, patient smoking. This is something we don't talk about much in scaphoids, but it is an independent risk factor. So for me, and this is the part where we get into what is Jim Higgins do. And you might say, well, that's interesting, but I'm going to disregard. But just to walk through this and march it out, for me, and I do have a low threshold for vascularized bone grafting, and I think we all have our biases, but for me, if a patient has none of the above mentioned risk factors, meaning their waist level non-union that's less than 12 months old, comes in without previous surgery, and they're a non-smoker and it's not humpbacked, that's the patient that can get cancellous bone grafting. Now, some would say that's a layup. And I think no scaphoid non-unions are layups, but this is probably the best one that's out there. If, on the other hand, you have any one of these risk factors, in my hands, that equals a vascularized bone graft. Now, you may say for you, it's going to be 2, or maybe it's 3, or maybe there's some that are specifically worse than others. And you may ask me, what do I consider the worst? And I've already sort of shown my hand, which is to say previous instrumentation. This is the most worrisome. And if you look in the literature, it'll support it. So if you look here in the left column, these are the 4 papers that you'll find. And I've gotten through this literature at length trying to figure out exactly what I should and should not be doing. But these are the 4 papers that compare revisions to primaries. The numbers are, in many cases, staggering. The difference between attacking, and I'm not talking about primary fracture, I'm talking about primary non-union, meaning you're the first person to go after the established non-union, versus you're redoing it. You're taking some hardware out and you're doing a secondary surgery. Those numbers are wildly divergent. So the redo, that's worrisome right away. In fact, there are only 4 of these papers here that are dedicated solely to revision non-union cases. And you can see on the top right how poor those outcomes are. There are these 3 that I would note do demonstrate really good outcomes for revision non-union surgery. Those are the exception rather than the rule. And for me, this paper here in the bottom right, Poulos et al., this is a great paper showing the power of the MFC in revision scaphoid non-union surgery. 84%, that's a good number in this game. Revision scaphoid non-union surgery. And for that reason, that's why I think the free vascularized bone flap really, that's where it makes a difference and moves the needle. If you look at those 2 randomized controlled trials, by the way, that I showed earlier, they find that revision surgery for scaphoid non-unions is so worrisome, there was actually an exclusion criteria. So I think you're in the office and you're trying to write up your series of, scaphoid non-unions. The revision surgery non-union is a different animal than the primary scaphoid non-union. So I'll just show you my algorithm. This is how it works for me. So if you have a non-salvageable proximal pole, we haven't gotten into that, but that's the osteochondral reconstruction. Those are patients that are less than 40 years of age, and their BMI is less than 35. And this is for reasons we've studied these patients down the road, and these are the patients that do the best, and that's where I restrict my indications. Osteoarthritis in these patients is rare because they're quite young, and lunate extension is not a contraindication. So those patients will get a salvage procedure if they have exclusion criteria of over 40 or a BMI of greater than 34. Or an osteochondral graft. However, if it's non-salvageable and they do not get excluded, these are patients that are getting MFTs, or medial femoral trochlea osteochondral flaps. And I can show you what that looks like. So what does non-salvageable mean? Literally for me, that proximal pole is non-salvageable if I'm the first surgeon going in and the CT scan sagittal images shows that the proximal pole is less than 2 millimeters. I just don't think I'm going to win. If I'm the second surgery and there's comminution, it's in more than one piece, the proximal pole. Or if this is tertiary, that's it. If the proximal pole is salvageable, which is by far the majority of these patients, and for me, again, previous surgery is super important. Humpback is probably the second most important factor. So if they've had no previous surgery and they have a humpback deformity, that's typically a vascularized volar distal radius bone flap or a Mathelin reconstruction. If they've had prior surgery and it's a humpback, I will use a corticocancellous MFC volar approach. If there's no previous surgery and no humpback, they can have a local, either 1/2 from the back or a Mathelin from the front. These are the best subcategory. However, if there's no humpback and they've had prior surgery, for me, that's probably going to be a free MFC. It's a little bit complicated, that algorithm, but that's as granular as I can get my opinions. And you'll notice the places that are circled here, that's when you get into free flap reconstruction. And the free flap reconstruction almost always sets in when I have revision surgery. So that's me trying to get as clear as I can about MFC and MFT, because I don't want you to think, and I appreciate, Jeff, you're asking me to be a part of this, to be the guy that's going to talk about MFC, but I just don't want you to think I'm just throwing MFC at everything or MFT at everything. But now, if it's okay, I was going to maybe show some cases. And
great, thanks, Jim.
So here's and we're all very familiar with the MFC. This has become amazingly commonplace now, I think, since it was first introduced by Cousin Turudoy, and this is just a turn of the century. So amazing how much has happened, how much has changed over the course of 2 decades. But the great benefit here is ease of approach, low morbidity. It is a large vessel that you can believe in. It is an anastomosis that is easy to perform. It's good caliber. It's a non-critical vessel, and it provides you excellent cancellous bone. And this can be big enough to open up any humpback. So this is a hugely extensile approach just to show you the blood vessels. But I'll show you in a minute when you do these for scaphoids, and this is a setup for a long bone reconstruction, just as a great picture of the vessel. But for scaphoid reconstruction, these incisions are typically 7.5 centimeters long, and I'll show you what that looks like. So keep in mind, the MFC, metaphyseal condyle flap, is a cortical cancellous flap, originally described, as I said, by Cousin Turudoy in 2000. And this is for treating the waist when you're putting it in between your own proximal pole and your own distal pole. So it's a shish kebab of distal pole, screw through the MFC and screw into the proximal poles, as shown here in the bottom right corner. Great results in 2000. I remember this coming out, and I was just starting my fellowship, and I thought, oh my God, free flaps for scaphoids? There's no way that'll catch on. And apparently I was wrong. And it was confirmed 2010 by Heinz Berger and the Mayo crew, saying that they did 12, and look, it worked really well. They've shown very nicely in this Yamamoto et al. Study out of Mayo that the perforators into the bone are densest in this distal and posterior aspect. It's usually a volar approach with an endocyte anastomosis into the radial artery. This is the pedicle being dissected. This is a lengthy incision, and I'll show you in a minute what they look like these days. But typically, this is a volar approach. You excise the nonunion generously. You do an endocyte anastomosis. You make the flap. Typically, it's about 10 to 12 millimeters in height, proximal to distal. We typically use the ipsilateral leg just because it's easier on the patients postoperatively. You do not open the joint, and there's no postoperative immobilization of the leg. So this is here's a waist level, right? This is easier than the case you showed, Jeff. A waist level non-union. He's previously failed ORAF with bone graft and K-wires, which were removed. So this is secondary surgery. Ignore the darkness of the proximal pole. We can't say what that is. And here it is, 3-month post-op CT scan. The one on the right is probably the one that's easiest to interpret, and this is reformatted so you can see the long axis scaphoid, but you see distal pole, MFC, proximal pole, showing incorporation. There's 1 year's post-op. So it's a really powerful tool. Here's another case. Again, notice it's waist and there's a DZ. So it's a humpback. This is 2 screws. Sometimes I'm not wildly crazy about 2 screws, but sometimes I'll put a screw in the MFC if I feel like I really want to get control of the actual flap. And there it is, post-op CT scan with correction of DZ. So really great approach from the volar to correct humpback. Preoperative CT of another case, waist level non-union revision, 3-month post-op CT scan with correction of DZ. Not great images, but pretty good. And 2 years post-op. So that's the MFC, but to be clear, when this proximal pole is non-salvageable, as I mentioned, and I sort of went through the indications of that, at least in my practice, that's when you get a case like this. The patient comes in. We all see these patients. These are not zebras. They're coming in and they're showing you this. It's a revision surgery. This patient's probably 20-something, and he's got almost nothing left of his proximal pole. And what are you going to do now? And it doesn't matter whether or not you like volar or dorsal approach to distal radius or free MFC, you cannot preserve that proximal pole unless you're a magician, I think. Now, this is a really bad example, and some of them are a little bit less bad. But if there's a big screw through a very small piece, that patient's getting a preoperative CT scan. And if I feel I'm not confident that they're going to win, and they've already had one trip to the OR, I don't want to be making a very long novel out of what should be a short book. So I will use the osteochondral flap. And this is what it looks like in a very extensile incision, again, just to show you what that pattern looks like. Here's this longitudinal descending geniculate artery, and there's a transverse branch. We use this longitudinal branch for the MFC, but there's this transverse branch that goes up proximally and then drapes distally to the periosteum and perichondrium of this proximal and medialmost aspect of the convex cartilage-bearing trochlea, the part that articulates with the patella only. So this is typically what these incisions look like. So if you're shooting for getting cartilage, it's an oblique incision that goes right to the trochlea, 7.5 centimeters, looks like that. And this is a longitudinal. So this was the goal here right out of the gates, was we're looking to just get corticocancellous bone. So I don't need to be up here by the trochlea, but that's about the same length, trying to keep the morbidity to a minimum. This is what it looks like in a close-up of these vessels heading up towards that bone and cartilage. This is a drawing that we've used to sort of demonstrate that you resect the proximal pole and then generously resect up to the waist. You're actually turning it into a waist problem, preserving the concave acetabulum that faces the capitate. So you're not resecting anything that goes in the midcarpal joint. In fact, you don't open the midcarpal joint. And then you resurface the proximal pole. Let me show you some specifics. Here's a great intraoperative fluoro after the resection. So keep in mind the non-union may have been down here. We resect that, and we keep the concave acetabulum that faces the capitate and go right to waist. You're making a nice big hole. And you might be scared about doing that, but next stop is a PRC here. So there's no treading gently through the night. Like, you go right to the waist and you create a favorable site, insert a good size graft. And that's what that looks like, looking from the back. And I approach from the dorsum. Heinsberger typically approaches volarly. This is just a difference of technique. And you're looking at the volar radius cave capitated ligament right here through the back. And this is an intraoperative fluoro showing the screw, which is now an antegrade through the flap or graft, depending on what you want to call it, and into the distal pole of scaphoid. This is what it typically looks like. And there's very routinely a sense of step off here, an appearance of step off, because the cartilage is so thick on the edge of the graft. It's way thicker than a standard scaphoid. So radiographically, it'll often look thick, and the screw will often look proud, which obviously bugs me, but it's because that screw is buried in radiolucent cartilage. So I'll show you what these typically look like. Here's a 1 year and a 4 year. And if you're interested in our original series, including both Heinz's and my patients, were in 2013. We subsequently reported a Baltimore-only series many years later, which is also available. But that's what they look like, and it does recreate the scaphoid form very nicely, and it's gratifying. Here's a typical case. So here's a 16-year-old that comes in. He's had ORF dorsal approach with a screw, and you might look at that and be like, "Oh, Jim, that's not that small." But if you run through those CT scan cuts, you'll see cuts where you'll say to yourself, it's going to be very hard to preserve that proximal pole. And it may be that if you get success with this flap, this graft, you might say, you know what, this is a thing that I know is going to work. And it's true. Some nails start to look like they're appropriate for your hammer. I will definitely admit that. But in this revision case with a small proximal pole that's fragmented, that gets MFT. Notice the non-union is not completely resected. So in an effort to preserve all the cartilage in the midcarpal joint, which is kept closed the entire time, I'll often keep this piece and insert the proximal segment. You can sort of appreciate it, I think, in all these pictures, right? And the screw is often very vertical. It's not the home run screw that we're used to seeing, because you're trying to go perpendicular to the non-union site, and you're also often trying to avoid the previous screw line. Here's a previous failure, dorsal distal radius bone grafting and screw, big screw, just as Jeff said, big trailing threads, a little bit of DZ, previous bone graft harvest site, notable. This is the preoperative CT scan, very small, intimidating proximal pole, screw through it. That's an MFT in my practice. So there's the MFT. Screw looks a little bit proud. You just got to You just got to put up with that. And here's a 4-month post-operative CT scan showing healing. I think pretty good correction of that lunate. It's pretty neutral. Good healing across here. Screws buried. 8 months post-op. And what I do when I'm staring at these, 18 months, I'm trying to say to myself, is there any pointiness of the radial stylet? Is there any narrowing of the space? I'm trying to avoid snack, right? That's what you're trying to do with these patients, avoid snack. 2 years. Maybe one more case, really small, blowing up proximal pole. That's not salvageable in my mind. Here he is, two years post-op. So in summary, and I think I'm doing pretty good, 736. So I said I'd speak to 740, but MFT, corticocancellous version, that's volar approach for a waist in my eyes. MFT, osteochondral, that's dorsal approach for a non-salvageable proximal pole. And I went through a little bit that algorithm of what is and what is non-salvageable, and also when and when I do not use free vascularized bone for reconstruction. There's that 2013 study. Here's a 2020 study. If anyone is interested in it, we did drill down a little bit more on risk factors. If I just may for a second, notice they're all young patients, and the previous removal of hardware, 35 of 41. So most of these are secondary or tertiary procedures. And our follow-up showed, in summary, just to blow through a little bit quickly, you can read this article if you want, but we were really good at getting the radiolunate angle near neutral. We were very good at radiographically restoring carpal height. If you were to summarize, how do they do? Their wrist flexion extension is about 65% of contralateral limb, and their grip strength is about 85% of contralateral limb. They generally don't gain any range of motion as compared to pre-op. So this is just a nugget of what I tell the patients in the office preoperatively. I said, this is the averages. Everyone can be a little bit below or a little bit above the averages, but anticipate having the same range of motion, but we're good at getting rid of pain, improving grip strength, and getting you tonight. And as far as we know thus far, and our longest follow-up is from 2008, these patients don't demonstrate progressive arthrosis. So if our goal is, number one, stop the progression of SNAC, our secondary goal, by the way, is demonstrate that we're superior to standard salvage operations. And that's something that's underway in our research division. I'm going to stop there because I feel a little bit like I'm lecturing. If there's any questions, it's 7:38.
Thanks, Jim. That's great. So you got the question. So Jim visited us at Michigan a few years ago, and we asked this question as well. But one of the audience members wanted to know your thoughts on when you do an MFT, medial-femoral trochlear graft. What are you doing with the scaphoid interosseous ligament? You shared some of your techniques and how you think about replacing the function of that.
Yes, and so that's a great question, and any hand surgeon worth their salt should be able to say, hold on a minute. The reason that we believe that we do so well, and we've demonstrated with, I believe, a critical eye, that these patients are not going into DZ, is, I think, twofold. Number one, we completely keep and Matt, just nod Jeff, just nod your head. You're seeing this X-ray, right? Still?
Yes. Yep.
Okay.
I see you're tracing out the articular surface there. Yep.
Yeah, that mid-carpal joint is closed. So the distalmost aspect of the dorsal and volar SL ligaments are probably intact. Now, you should be raising your eyebrow and saying, wait a minute, that's about the smallest percentage of the SL ligament possible. And I agree with you. We took this to the lab to try to study why is it that near total obliteration of the SL in these patients will maintain neutral alignment. And we thought it was because we were doing what we termed overstuffing the scaphoid. And we indeed studied this with AP and lateral radiographs that were reproducible using a cadaveric model. And we first destabilized the SL and proved that we could make a DZ model. We then cut the scaphoid and put the proximal pole right back in and proved that it stayed DZ. We then inserted a 2 millimeter piece of artificial scaphoid in the waist so as to supersize, so to speak, the scaphoid. And it turns out it corrected the DZ. That was our crude way of trying to demonstrate that if we overstuff, and we're borrowing that term from like radial head replacements, but overstuffed the scaphoid by making this segment as big as we possibly can, that we can not only correct a DC, but keep it in neutral. And I truly believe, based on our experimental studies as well as our clinical series, that that's accurate.
Great, thanks. So one other question, and then maybe as we transition to Rachel's talk, your thoughts on morbidity to the knee. Is this something you do in runners and athletes, or is this something that the knee is precludes you from thinking about it?
So we've studied this at great length, and there's two other studies. I wasn't going to go into all that, but it's obviously one of the most worrisome things. We hit all these patients with a barrage of lower extremity outcomes measures. Some of them are shown here, and we have studied one of those patients have what is considered below the MCID of outcomes as compared to the preoperative study. After these barrage of studies, and these are the majority of them, we found one sports module called the COOS sports module that demonstrated that we had a subgroup of people that were performing below the MCID. In other words, i.e. parentheses, you're making them worse. And of course, we zeroed in on that and looked for risk factors. What did we find when we looked at risk factors? Were that we looked for gender, age group, previous DZ, and hand dominance and BMI. Some of the stuff held up in multivariate analysis, but when it came down to eliminating the effects of the other influencers, it turned out that only BMI was actually truly relevant. And so if we eliminated patients whose BMI was greater than 34, it made a huge difference. And we did a scatter chart of this showing it. So summary, that's why I showed earlier that the BMI for us is a strict cutoff. Age and BMI. That age I actually made up. I said, if we're going to do this as sort of a novel procedure, I'm not going to do it on anyone older than 40, because I think that's when people just start getting their meniscus fixed after running and things like that. We want knees that are free of pathology. And our second criteria is based on these studies showing that the BMI has to be less than 35. So what does that mean? Because I'm not very good at measuring people up, but if you're 5'9", 235 is a cutoff, and if you're 6 foot, 255 is a cutoff. So if those patients are larger than that, I will tell them you are at an increased risk of having trouble with your knee after this operation. Not trouble like you're crippled, but trouble like you're not going to be performing as well on these patient-related outcomes measures. And for those reasons, I will offer them other options, including salvage options or rib grafting, which I didn't talk about, or hamate would be another option in this subcategory.
Great. Thanks. Well, thanks, Jim. So a couple other questions we may get to later, but Rachel, why don't you pull up your talk?
All right, so I'm going to be talking about rehabilitation considerations for the scaphoid nonunion. So let's see here. There we go. Oh, went too fast. So the first thing I kind of start with is the conversation between the physician and the therapist. I think that's really what I start with the majority of any patients that we're taking care of. And the reason that is because, especially with this population, they're not following normal timelines. The physician may have particular ideas and times that they want us to be following in regards to how much stress we're creating with rehabilitation protocols. And then considering like how much weight we're transmitting across the wrist. Remembering passive motion is going to create load. So I feel like that communication is important. So we know what the expectations are of how much weight, how much stress you want us to be putting across the wrist once they're coming out of that cast and maybe going into custom orthosis or something like this. The other thing that I consider is the population that I'm dealing with. So people that are at higher risk for nonunion, this article that I have here on the left is a review of a claims database. So this is large numbers, like a cross-sectional look. More if you're higher risk for nonunion, if you're younger, you have male sex, if you have surgical treatment. And the way I think of it is the expectations of the population. So a lot of the times it's younger, more active person. So there's quite a disparity between their current situation and their expectations. And I find a really important part of rehabilitation for this population is helping to make that match to keep their buy-in and keep them kind of like paying attention and listening to your instructions. I'm expecting that typically the physician is going to be asking for us to be doing all of these interventions that you see here on the right, moving from the lightest at the very top with active motion, passive, joint mobilizations. We're always going to be working on pain modulation. But if you look at the graphic, the words that are in yellow, I feel like really helps to strengthen buy-in with the patient. It keeps them engaged. And there's a way to really toggle the intensity of all of these exercises. Even when we're talking about strength, there's ways to make the strength lighter. I find including the entire kinetic chain, functional kind of activities helps people to keep engaged, and also focusing on proprioception, which can make the rehabilitation a little bit more interesting instead of pick weight up, put weight down. So we know that these people are going to be tight, right? So when we're working on mobilizing in general, I tend to work from the least amount of force to the greatest. And you'll see the step up, like obviously we start with active motion, working towards passive. And eventually, if we're not getting our motion, we might want to use static progressive orthosis. You see a couple examples of static progressive orthoses here that are custom made. There's also prefabricated that your therapist might be asking for. I work on proprioception. This is a way that I really feel like I keep patients engaged because proprioception can be a lot of fun. And whenever I'm working on proprioception, I like to start with the joint position sense, which kind of gives me a starting place of where we're at, how restricted they are with proprioception. And so the study that I have cited here shows the minimal clinically important difference. And this is in a population of distal radius fractures. A lot of the research for some of the rehab procedures are around distal radius, I think probably because they get such high numbers. But I feel like some of this can apply to scaphoid since we're dealing with a risk condition as well. When you're working on proprioception, you can go from things that match active motion. So we see some of these apps that are a lot of fun for people to work with are on the very top of the slide. And then over here to the left are activities that are matching more active motion where you're working on joint position sense, reactive muscle activation with no resistance. And then moving towards things that are more plyometric, we see weights. We see somebody using a gyroscope, which uses centripetal force and pulls in different directions. You can have them move in a variety of different ways to continue to challenge themselves, keep it kind of fresh and interesting. And so that's what I say to myself with strengthening. There's lots of ways to keep it fresh and interesting without making it just pick weight up, put weight down, just the traditional wrist curls and things like that. You could use blood flow restriction therapy, which is what you see here on the left. And this is a way to start strength really early or earlier. I know that a lot of times this population, the people are going to be immobilized for a significant amount of time, but starting some strength earlier with lighter amount of resistance and helping them to gain the strength. With younger populations, people really like that particular intervention. And then the videos you see playing here on the bottom on the right are some closed kinetic chain exercises, some open kinetic chain exercises, adding variety of resistance in different directions and using the entire body to challenge the patient. But then, like you see, some of these are highly resistive. So we would want to communicate as to when the physician wants this to be happening. And then I'm going to end with just a little bit of information on blood flow restriction therapy. So it's just application of an inflatable cuff that decreases venous return, and it helps to gain strength earlier for people. It's been shown safe and effective in distal radius fracture patients. This is probably the only population that is really well researched in the upper extremity. In healthy subjects, blood flow restriction has shown to strengthen not only the affected side, but also the non-affected side. So maybe there's a place to put this on somebody's non-involved arm and help them gain strength because it can create a systemic effect. And it's a nice way to gain strength early with lower forces, but still needs some research in this particular population. So thanks very much for letting me share, and I'm going to turn it over to Rob.
Thanks, Rachel. Excellent. So, Rob, if you want to, we're getting a few questions. So just as a reminder to our audience members and participants, please feel free to ask. There's a couple questions that I've saved up after Rob's talk that we'll go through with the group.
All right. Well, good. I'll go ahead and get started. Let me know if you don't see this. My charge was to present a case kind of for open conversation of scaphoid complication-related material. So I'll definitely call on Jeff and Jim to provide a little bit of opinion and insight as I go through this. So there's a 19-year-old male. He was in a motorcycle crash, unknown speed, early 2021, February, right wrist. He was seen at an outside hospital, diagnosed with a scaphoid fracture, treated surgically. At 6 weeks, his physician returned him to full activity based on promising radiographs, but he saw our office 1 year post-procedure with persistent pain and weakness in his wrist. The pain was primarily with axial loading and extension loading, no pertinent medical history. You can see he is an amateur motorcycle racer and a non-smoker. Briefly, his physical exam, tenderness at the snuff box. He was lacking 35 degrees of extension, just 5 degrees of flexion compared to the contralateral side. His grip strength was at about 60% of what would be expected. Good digital and forearm motion. So if we go kind of back in time, we were able to retrieve his initial radiographs from when he presented to the outside hospital. You can see these views. So I guess one question I'll ask you, Jeff, if this was your patient, they came in day one, would you get a CT scan on this injury or no?
I would not. In other words, there's enough here that it's a non-union. I mean, I guess if you wanted to get a CT and have some concept of the amount of flexion through there, you could do that. So it could give you information about that. But for me, the decision is made from the plain films, so I don't need it.
And again, I heard you say it's a non-union. This, again, just a reminder, these are the original radiographs from when he presented at the outside facility.
Oh, I'm sorry. I thought this was the 1 year. Sorry. Okay.
But same thing applies, Jeff. So first time meeting the patient with this acute injury, no CT.
So that's a different question. So acute injury, there was a series out of HSS where they actually got them in patients that they were thinking about treating non-operatively just to rule out a flexion deformity. So it was almost a criteria to decide on if the patient remains a candidate for non-operative management. And that was a pretty impressive study. They showed some pretty benign looking plain films that actually on CT did demonstrate significant flexion through there. So for someone who is going to be having conservative management, I would think of getting a CT more commonly.
Okay. All right. Jim, anything to add? Do you in general agree with that?
Yeah, I think the indications for CT in an acute fracture would be if you're unsure of the size of the proximal pole. This one, I think everyone would say is pretty big. And then if you are unsure of displacement, meaning you're considering a PERC approach and you wanted to know, is it translated or what's the interscaphoid angle? To me, though, I will say this would raise an eyebrow, right? Because there seems to be more of a fractional line than you would expect. And I'd love to know if there was some maybe cystic resorption at that site, meaning indicating that perhaps this is the kind of fellow that may have fallen off a motorcycle more than once. And if that were the case, you'd be heading towards bone grafting. It looks like there's a pretty big gap there.
Yeah, it's a little strange. The scaphoid looks tall, and the morphology of it doesn't look too bad, but there's definitely a little bit of a gap there. It makes you wonder, right? So this patient had a CT scan, and maybe you can see what I'm pointing to with the arrows there. Small fracture through the radial styloid, small fracture on the volar part of the triquetrum. There were no reformats in the axis of the scaphoid, but you can see representative cuts of there's proximal pole, there's distal pole scaphoid, and there's an extending lunate. Jeff, does the fact that you see these fractures of the radial styloid and the triquetrum change anything you would do?
It might actually suggest a little bit more of a greater arc type injury, meaning that the force went beyond just the scaphoid, and you have transradial styloid and transtriquetral, variation. You do see that DC, or that midcarpal flexion. So that sort of suggests that the midcarpal joint isn't completely normal. So that, and the sort of the distraction of the scaphoid, probably suggests less of a stable injury than I might otherwise expect with a simple waist fracture.
Okay. Jim, if you don't mind my asking, what would be your surgical attack now on this, seeing what you see?
Well, I think it would definitely be open for starters. And I think we're all there, right? So
there was a question, not to belabor or go down a rabbit hole, but there was a question about anyone's role for minimally invasive. So I think in this one with displacement, maybe not, but Jim suggesting that this would be open, does that mean you do treat some arthroscopically minimally invasive?
I've treated acute fractures with arthroscopic assistance to ensure that my reduction is as good as I think it is, but I wouldn't do this. Now, there are certainly surgeons that can do that are better at arthroscopic assisted ORIF, but this would be one that I would treat open, yes.
Yeah.
All right. And Jim, would you go open volar, open dorsal? And would you plan on having to do any sort of ligamentous work with the possibility of a greater arc?
Well, yeah, I think we know that that's not common, but it is possible that there could also be a ligamentous injury. It's kind of unlikely given that you see some sort of greater arc injury at the capitate, but that would make me want to open it up, and I would want to see it dorsally. So in general, for waist fractures, my strong preference is to go volar on them, but in this one, I would go dorsally. Okay.
And what's interesting, you can see this, how far the proximal pole of the scaphoid is from the distal pole. There's elements that are much more displaced than they originally appeared. So this patient was treated at the outside facility with an ORIF via volar approach, no type of ligamentous work. Here's the 6-week radiographs we were able to retrieve. And it was based on these radiographs that the patient was returned back to full activity as tolerated. I'll say, Jeff, do you see anything you don't like?
If I could pick 2 out of 3, I'd be happy. But unfortunately, I do see all 3 of the X-rays. So that X-ray to the right is concerning, and that's sort of a view that I'll often get in the operating room. And this is why those first 2 views on the left are why people get more than just plain films to decide on if it's healed or not. Because you could easily be convinced on those 2 films on the left and the center film that it's healed, and obviously the surgeon was, and that film to the right, that scaphoid profile view shows the real story.
Yeah, and that what Jeff's pointing to, I think, for the audience is that you see a little bit of dorsal gapping there as you go into this semi-rotated view. So we'll go ahead. These are now the 1-year radiographs. Doesn't look like there's been a whole lot of change. Probably a little halo around this hardware that's in the proximal pole. Still looks like there's a radiolucent line through the waist. The oblique doesn't look too bad. Obviously, with all the bony overlap, hard to see much on the lateral. Here's the CT scan now. This is at 1 year. We'll pan through first the coronals. Overall screw placement and trajectory, I think looks pretty good with this, although you can see that lucent line that still goes across the scaphoid, and it's there on numerous cuts. This first sagittal I'm going to go through, this really shows the scaphoid, and you can now see what looks like a potential nonunion line traversing through much of it. Okay. Also worth pointing out, and I'll pause the video here when it gets to it, is you see, oh, sorry, skipped ahead. Let me do that again. Sorry, guys. I'm going to try to pause it. My fat finger got in the way. I don't know why it's advancing when I try to pause. I'm sorry. Instead of pausing. What I just want you to see as it goes into that proximal pole is that screw is quite dorsal within the proximal pole, which in my mind raises the question, either the screw is just purely dorsal or it might be under-reduced, right? Because if you have still a flexion deformity, the proximal pole is almost going to flex to the left side of the screen, and you're going to lose a lot of the bone stock. It's going to vanish volarly, if that makes sense. Imagining kind of booking that open more into an extended posture with the proximal pole, it would actually present you more bone for purchase. And then this view, what I'm just trying to show here is you'll see that the lunate is still pretty significantly extended, which I think raises the suspicion that maybe the fracture was somewhat under-reduced. So, and I know, Jeff, we were allotted 10 minutes. I don't know if you want me to skip ahead to treatment. Do you think we have time for me to poll Jim and you on what you would do?
No, go ahead.
If you want to be on time. All right. So, seeing what we see, Jeff, what would you offer for this patient?
Well, again, I think you pointed out that the combination of the lunate being dorsiflexed and looking like flexion through there, I think there's an opportunity. There's not too much windshield wiping of the screw. I think removing the screw, choosing a slightly larger screw, bone grafting. In these, what I'll do is I'll flex the wrist, pin the lunate neutral, then open up the fracture, and then that helps guide me and figure out how much humpback I need to correct. So in this situation, in a young, healthy person, this would be cancellous graft, volar approach, and bone graft.
Okay. Any tricks on how you can get better placement of your screw?
Well, again, I think if you extend the fracture, your screw trajectory, as you said, is going to wind up central in that proximal pole.
It's going to naturally get there. Yeah. Okay. Jim, as I look at this case and having heard your presentation, I would think if this patient's in your office, this person's getting some sort of vascularized bone graft. Am I wrong, or is that the way you would think about this?
Yeah, I would use an MFC from the front, a corticocancellous MFC from volar, and really, I think a Matholin is another option, but those would be the only two things I would consider, because I would absolutely want to open up as much as possible, and I think it's almost impossible to overextend the scaphoid. So I get as much in there as I possibly can with cortical strength. So that's a tricky case, and I think the keys to it that I always focus on are trying to get in as much as I can, trying to place the screw very volarly, meaning the trajectory of now the new screw is going to be very volar, attempting to capture my own flap as well as the proximal pole. And I do like the technique that Jeff referred to, the sort of so-called Linscheid pin, which is, say, hyperflex the wrist, get the lunate to neutral, radial lunate pin, bring the mid-carpal joint into extension to open up the fracture plane, then fix the scaphoid. You can decide whether or not you want to remove that radial lunate pin or keep it for a few weeks postoperatively. But so volar approach, as much extension as possible, volar placement of screw. And then the last thing is getting the flap inside the actual clamshell of the scaphoid, meaning getting the cortical surface of the MFC or the Matholin dorsal to the volar cortex of the distal pole and dorsal to the volar cortex of the proximal pole, as if trapping this flap in there, because one of the unsettling things that can occur when attempting to correct that with a vascularized flap is that it spits that flap out volarly as the compressive forces continue over the next few weeks.
Okay, great. And I'm sorry, Jeff, are we okay with still another 5 minutes or so? I don't know how we're doing on time. You think that's all right?
Yes, I do.
Okay, so just a question, Jim. As I look at this, it seems like one of your strongest indications, like you said, for vascularized bone graft is having had previous instrumentation. In a case like this, where that fixation in the proximal pole is only probably capturing 15 to 20% of the dorsal bone, there's still a lot of kind of untouched bone in the proximal pole. Does it become a softer contraindication if the screw, we see some of these come in where people practically miss the proximal pole, it's common where they under-reduce it, they don't remove enough of the trapezium, their screw ends up being too kind of horizontal on the sagittal view, and they practically miss it. So do you think that matters if the bone is relatively untouched or less touched?
I totally agree with you. And if the screw is going to be in the fracture plane, it's going to be in this fracture plane, right? It's not going to miss the proximal pole volarly. It's going to miss the proximal pole dorsally. So it'll be in the junction between the dorsal fracture line of the distal and proximal poles. Exactly. Just what you're showing here. This is the error. And it's easy to miss that on a fluoro intraoperatively, right? So, but to answer your question, probably, but no one knows that right? So does that drop that index of concern with revision surgery if you don't like the first surgery, or you think that the fixation it wasn't really a good swing. The person didn't get a good attempt the first time. It makes sense, right? I agree with you. That makes sense. We just don't know that. So
yeah, hard to know. Yeah, that's what's interesting about these cases like this. I mean, so many different ways to skin a cat, with Jeff and Jim doing two very different things. So in this case, what was done, remove the screw from the volar side. Okay, so you can see a relatively large defect once that's reduced. You mentioned the radiolunate pin. At our institution, we've actually come to like this mid-carpal pin very much as far as writing the lunate. So once the non-union is mobile and the capitalunate joint is free, it's basically the inverse of the radiolunate screw, but one you can leave in longer. So you can start this pin, and this is the kind of pin we would use for four-corner fusion. So you start it in the index long web space, drive it through the capitate towards the lunate, and then once it's heading towards the lunate, you can then extend the capitate on the lunate, extend it as much as you want to or beyond neutral, and then drive the pin down to capture the lunate. And we'll typically leave that, at least I'll typically leave it in at least 6 weeks, just cut it below the surface of the skin. Although you could leave it proud up to about that long. But I think it has two kind of advantages. One, like Jeff was alluding to with the radiolunate pin, it really helps you intraoperatively because it maximally flexes the proximal pole of the scaphoid. So it helps naturally open up that gap without it really you struggling to manhandle it with a joystick every time. And then really, once you have that control of the proximal pole through the lunate that's been righted with the capitate, then it's just a matter of maximally extending the distal pole of the scaphoid to open up the gap as much as you can. And I agree with Jim. I think it's almost impossible to overextend a scaphoid. So you just pull the hand over a towel literally as far as you can into extension and just open up the gap big. In this case, the decision was made to then go to the dorsal side for the fixation with the screw. And part of that was believing that if this operation was going to fail again, unless it was a failure of biology, it was probably going to be a failure of still inadequate fixation in the proximal pole. And I think everyone goes in with a very good intent of placing that retrograde screw perfectly in the proximal pole. But like you said, Jim, it's hard to see it on x-ray. It's a little bit hard to know. So decision here was put the screw in through kind of a mini open dorsally, believing that you could kind of optimally get it started in the proximal pole where you want to try to stay out of the old hole. And this was non-vascularized autogenous bone grafting from the distal radius. And just if you look at that view on the right, you can see it's a much more vertical screw trajectory now, right? So remember the line that old screw was taking, like Dr. Higgins said, almost coming out the fracture dorsally. This one has a much different starting point, way around the turn volarly. So that should be in all that good bone that wasn't touched before. And then this is just a CT scan I can briefly run through that just shows that it appears to have good healing at 9 weeks post. There's a little bit of a gap volarly, but all the cuts going dorsally show it to be pretty well healed at 9 weeks. And then this is the patient at 3 months showing good union. So I'll pause there. Thanks for letting us go slightly over, Jeff.
All right, excellent. So just to hit a couple of the questions, and I'll sort of tie it into this case. So one of the other thoughts and worried about not having enough bone, there was a couple of questions about the role for scaphoid plates. And Jim and Rob, what are your thoughts? And Rachel, have you seen any in terms of rehab?
I never use plates, and I think it's just lack of experience that I'm talking. But I think the issue with vascularized bone grafting in particular is just very difficult to get the pedicle in there with a plate in the way. It's just very difficult to do that. So I think it would be the people that speak mostly about plating are people that are cancellous grafting or treating primary fractures. So in the setting of scaphoid non-union, I think you saw my threshold and algorithm is pretty low for vascularized bone grafting in some minority of cases that I'm treating with non-vascularized bone grafting. And so plates don't really have a role for me.
Gotcha. Rob, any use of the plates? And Rachel, have you seen any patients who have been plated?
I've never taken care of a patient that's been plated, and that's probably just where I work and the surgeons that I work around. That might not be something that they use regularly. So I've not had that experience because my whole career I've been in Baltimore. So.
I've done some scaphoid ICLs and seen some plates, and the nice thing about the fixed angle plates is you can get purchase in a completely different plane than the prior screw may have had, so you're into new bone. But it's tough to get proximal pull. I don't have any experience with it. And then another question, and Jim, you brought this up in your talk about the role for smoking. Is smoking cessation an absolute mandate, or does that just color your choice of vascularized graft versus non-vascularized graft?
I'd say, I'd love to hear everyone else's input on that, but I can't make anyone stop smoking, so it's not a prerequisite for surgery. And I would say among that list of risk factors, it's the weakest or the least concerning for me. So yes, I think it moves the needle in terms of risk factors, but it doesn't preclude surgery. And it's not as concerning as, say, for example, previous instrumentation or humpback deformity.
Gotcha. Rob? You're muted.
My thought is, unless the surgery is majorly time sensitive, like they're not working and they need to get back to work and the wrist is getting in the way of it, I'll usually ask them to try, give it maybe 3 months to look them in the eye and say, if you've ever thought about quitting, this is the time, because we believe it negatively affects healing. And I think there's been a handful of patients who, at least during the perioperative period, were able to cut down their smoking a lot, either quitting or cut it down a lot, which I think does them a personal service just for their general health. So I'll give them a few months for them to get it as low as they can and then go from there. The only treatment change I'll make is if it's a non-union, I'll have a lower threshold to use iliac crest. I think the data does suggest it's a little bit better bone graft when you look at all the biologic factors compared to distal radius. So I'll use like crushed cancellous, iliac crest instead of distal radius if someone is like a multi-year chain-ish smoker.
The interesting thing as of late, and for those of you who are in states that has marijuana legalized, patients that consume not cigarettes but other smoke products can readily transition to other variations, and they sort of do so happily. They'll say they can quit smoking and move to another product that they get at the same dispensary. Stopping smoking cigarettes is a harder thing. I agree, Jim. All right. Well, excellent. Well, thank you, everyone. Our sage, Jim Higgins, Rachel, and Rob Wysocki. Thank you, everyone, for your participation. Thanks, Chris and April and Beth from AO. And again, this will be available on the YouTube channel. Have a good night, everybody.
Thank you.
Thanks, Rachel. Thanks Rob. Thanks, Jeff.